Just a quick overview of Intermountain Healthcare if you are unfamiliar with us. So we're the largest private employer in the state of Utah. We have 22 hospitals. We've got about 2,800 licensed beds. We do home care, and we've got urgent cares. And we're now starting to grow into this for-profit side, and really where we can get heavy into R&D, cancer research, Navican. I think a lot of you are familiar with that. Genomics. So we have a new CEO that has a completely new and modern vision that we need to be reinvesting and disrupting first our own system. So rather than continuing to compare ourselves against ourselves and make that the benchmark, we're trying to really compare ourselves to everyone else and what are they doing well. We're in the process of building a center where we'll bring in other experts into the field and then have them both teach and learn from us. So there's a lot of good work, a lot of things are happening. We've been in the news recently. They're taking an approach of strategically aligning with large organizations in some areas of our business. So anyway, it's fun to see where things are going. Okay, so let's jump right into it. I think a few of you have probably seen a slide similar to this. Maybe you can replace your own role. I know not all of you are CISOs, but this is how I think a lot of us feel. You know, often we ask the question, what keeps you up at night? Well, no one ever asks us that. So I'm hoping to give a little insight into what, for you non-CISOs, including myself, what really does keep us up at night. So it seems like everything's an increase. There's an increase of data breaches, an increase of attacks, an increase of attack surfaces. How many of you are wearing an IoT? Yeah. How many of you have an Alexa or an equivalent in your home? Everyone, right? So we'll talk more into this later in the discussion and definitely later in the panels, but I don't think that the opportunity and the risk will decrease going forward. We're only increasing there. Spear phishing is very heavy. A lot of organizations don't like to talk about if they've been phished or spear phished. We definitely have. We have good technologies in place to block it, but no technology is perfect. So it's a lot of emphasis on educating our employees, which we now call every employee a caregiver. I don't know if other health systems have made that move as well, but from janitor to doctor and everyone in between, in our system, we're all caregivers. So I hope that's a takeaway that each of you can have. And what's fun is to see clinicians just like Dr. Young and others attending events like this, nodding their heads saying, yeah, there are people in other roles, non-clinical roles, that are caregivers. So let's talk just for a quick moment on security spend. So this was put out by Gartner just last year. We know banking and finance typically allocates the most amount of IS dollars to security dollars, and it's almost hitting 8%. If you were to look at this graph, and I won't ask you to tell everyone what your IS spend is related to security, but I think this holds true. You know, in healthcare, we're somewhere between 4.5% to 5.5% of total IS spend. Any payers in the room? So insurance plans? No? Okay, they tend to have a little bit higher allocation to cybersecurity. But in general, does this kind of reflect what your institutions are? I've seen a lot of heads nod. So that's one thing that kind of keeps us up at night. You know, if we look at the number of breaches, if we look at the cost of the average breach, that's gone up as well. Again, all of these increasing. The Podium put out the study, and over a 4-year period now, healthcare breach is $380 per record. So we're almost 3 times the amount of the average. That could keep you up at night, right? So before we jump super deep into value-based care, let's just be candid. I'm not an expert on value-based care. Michael Porter, Harvard, I think he understands value-based care. I think our clinicians understand. I think some of our IT executives are starting to understand it. And it's another movement, just like we've seen in the past, where the business, they're the forward thinkers. They're the ones that are thinking, how can we disrupt ourselves? How can we plan for the future and survive in the future and compete in the future? And typically we follow them. I'm seeing a shift now, not just at Intermountain, but in a lot of other health institutions where the business is bringing along our CISOs, our CIOs, our CMIOs to say, let's do this together. And I'm seeing heads nod. I can't tell you how encouraging that is. So I did a quick Google Trend. Have you guys done Google Trend searches before? It's pretty fun to dig into it. So I compared two things, value-based health, which is the blue line on the bottom, and population health. I did it over a 3-year period. I made sure to tailor it to the health category, and I just did US. So over 3 years, you can see value-based health hasn't gotten the attention that population health has. So there's work to do, a lot of work to do. I think it was, again, quoting Michael Porter, I think he said, and I'll paraphrase, I won't quote, we have attorneys in the room, so to paraphrase, he said, to understand value-based care, we have to understand what value means. So I was like, well, maybe Google's not working. And then I went and said, what are people searching for today? And these are the 3 top things that they were searching, at least as of a week ago. Trump administration, Super Bowl, and Grammy Awards. So Google is definitely working. This is real. This is an opportunity. We have a lot of work to do to educate not only those within our system, but our partners, our vendors, everyone we integrate with. They need to be knowing much more than the buzzwords of blockchain, AI, interoperability. They need to know what this model is all about. So here's a couple quick graphics that as I was Googling, I wanted to just see what are people really saying value-based healthcare is, and how simple can they make it. So just like any good sales and marketing people, it's icons that try and explain the story, and I think this one does a good job of separating out the cost versus benefits. I love this one. So you've got the CEO, who's the kicker, who's kicking the ball, which is revenue, into the field goal, which is the performance benchmark, and your payers, your insurance plans, are the refs, right? And if you notice the field goal, it's being swiftly shifted as the performance benchmark. I mean, this is a little cynical, but honestly, this is where we're at right now in terms of everyone knowing the benefit of value-based care and care based on quality. So we'll dive into this model because I think this at a higher level really talks about the things that we're trying to achieve. So if you look at top left, patient care provides patient clinical grade feedback on their condition and instructions on what to do next. So we do this now. It just takes a month to get that feedback. My grandpa recently, he's in his 90s, he keeps passing out, and they can't figure out why. So they sent him home with this heart monitor that literally, I mean, it looks like he's wearing a bomb on his chest. And they say, wear this for 2 weeks, and hopefully you'll pass out in the next 2 weeks. And if you do, we'll capture it, and then we'll plug it back in, and it'll take a month to analyze. And if you haven't died by then, we may be able to help you. Does that sound wrong to anyone? The technologists in the room are thinking, come on, I can wear something on my wrist that can probably capture the same data, that can send it to them real time, that can get me that treatment quicker. So that's part of the value of patient care. Data that's measurable, I'll get into some concerns I have about this. My biggest fear about this movement to value-based care is that we're going to be so focused on the aggregation and consumption of data and feeding everything that we possibly can and then not knowing what to do with it or having the resources to parse it. or how to put it to where it's valuable and in front of a clinician's eyes, then they're spending more time looking at the computer rather than they are actually working and visiting with the patient. That's my biggest fear. So that's obviously a key part to value-based care. Coordination of service and care. I think the days of having an 8 to 5 office closed during 12 to 1 for lunch and picking up the phone when you want to are over. I think they're long over. It's no longer what's convenient for the doctors, but shifting to getting care how, when, and where the patient wants. Right? I mean, we're in this age of, I don't want to say instant gratification, but we're in this age of real time. There is not I don't think there's much room for growth in this older model. And you've seen this with CVS and Aetna joining, right? You've seen where now you go to a pharmacy to be seen first by a clinician, to be diagnosed, and you walk next door or to the next window and you're now getting your prescription. It's a one-stop shop. So you're starting to see that shift. And again, I think more of the focus is going to be on that real-time data that we get back. And then, of course, communication and collaboration. I think the days of calling the patient when it's convenient, you call when they need that care, and the patient, and the collaboration, the communication goes both ways, right? In order for the system to work, the patient has to give back. And I think that's a big challenge that we're going to run into, is you'll have a lot of folks that are all in on, I'll wear whatever wearable you want, and I'll give all my data so that I can be healed quicker, versus we do have a population that is, I just want to be healed, don't make me wear things that look like bombs. So for our CISOs in the room, this is the model you've seen or are currently in or will move to. This is the future value-based care. So in your minds, you really need to replace everything on the left that's good for the business with, now what does that mean for my day job? Now I haven't been comprehensive in this, but I've tried to put some type of correlation so that you can very easily relate with and say, if our doctors are saying we have to provide patients clinical grade feedback on their conditions and what to do next, now how do we do that safely, securely, that meets our regs, that doesn't constitute breaches? You know, you've got this whole debate, can I text our patients their medical information? Even our regulated agencies can't agree on whether or not that's okay. I mean, so you're starting to see really why they don't always sleep at night, right? This is the problem they have. So for our vendors and partners in the room, I hope that as you look at the model, you consider the things from the CISO's eyes. And for our clinicians in the room, I hope that that's something that you can pay attention and appreciate and work with us on, that we're not going to be the shop of no, we're not going to do this, or no, you can't do this, but let's find out the safe way to do this. So again, that's why I'm so encouraged to see clinicians participate in forums like this. Likewise, I hope we can be invited to participate in their forums. I think we're going to have that partnership moving forward. So any other ideas from folks when you look at the two and compare them? What goes, I hope this is interactive. I know it might not be the best for the video, but any other things that you want to add or can think of maybe some opportunities? I won't call them concerns or problems, but opportunities. How do we manage privacy and security? The third bullet, I think our clinicians can relate with. Are we going to give them data that will add value, or is it just going to make their job more difficult? That is a big concern of mine, and in a way that's consumable. So on the payer side, which is what my team covers, there was a recent study that was done, and cybersecurity didn't even hit the top 5 of priorities among over 100 payer systems. I think receivement of payment reimbursement was like clear at the top, and number 6 on the list was cybersecurity. I will say, because we are a payer provider system, we have very tight integration. So our CEO is as much a CEO on the payer side as she is a CISO. I mean, it's phenomenal. So to be able to have that alignment, it actually makes me cry at night sometimes. There is a transition period as we move away from fee-for-service to value-based. There is a true transition period for us in security that will take time, patience, and it will not be without bumps. So let's get into some of the data then. So there was a recent poll done among other healthcare organizations. We looked at everyone and how big of a data lake, mart, warehouse, and it came back. Intermountain actually had the largest healthcare EDW. Now, from a security perspective, I don't know if I'm proud of that or scared of that, right? That means we have a whole lot of data, and the more data you have just means a whole lot of risk. So I think what we'll be able to get from it is actually getting rich data that we've collected over years and then putting them into modern models and algorithms to actually get that value out of it. So that's just one thing I wanted to highlight, that we very much are invested in EDWs and invested in collecting data right now in every possible way that we can. Now, that presents some challenges for our CISOs and security folks in the room. It's so great to collect it, but now you got to start thinking, how's it traversing the network? What port's it going over? How are we connecting with the partner? Is that partner under an NDA? Do we have a BAA in place? There's all those things that I think at the high level we don't consider. They're all necessary in order for us to provide that data to our clinicians, the folks making decisions and research, but there's also all this other back-end stuff that we've got to work out. I want to get into just 2 or 3 use cases of how we're using data analytics right now to provide better care. So we know with data we can save money. I don't think initially that was the case. I don't think we just had this magical pool of data and we just started saving all this money and pots of gold and rainbows started popping up. That didn't happen. It took time. It took data scientists, CMIOs. It took a lot of really smart people to say, how can we use what we've collected so far? And it is proving value. So we know that if we can't get a patient's temperature to hold true or get to become normal within 5 hours without intervention, we don't send them home. We know that if we have a mother come in early pregnancy, but less than 38 weeks in gestation, it will cost 7 times more than if they had delivered between 38 and 40 weeks. We know there's 9 steps that we can take every time there's a cardiac event, that if we follow those 9 steps, we have a much higher percentage of sending them home in 18 hours and not having them return within 30 days. We know all of that because of what we've collected and analyzed and researched and then implemented because of our data. So the takeaway for you, if you don't have a large data warehouse or you're just now starting to build one, or you don't have a data scientist or are not heavily invested in there, is you now have the opportunity before you to start collecting this data to then being able to implement in the clinical world. So for our security folks, this part of the presentation really will be geared towards you and your shop. I love technology, but I also love fundamentals. I'm big on them, and I will speak for Carl West here. Our belief is that this way to modern value-based healthcare is just repeating and getting honed in on the fundamentals, right? So there's the whole Vince Lombardi, gentlemen, this is a football. Now we're saying, ladies and gentlemen, this is a firewall. We're saying not quit looking at, but don't ignore what we've learned in the past just when we're looking forward. There's a big win, and I think some value add there. So 4 ways to manage risk. What are they? You guys are all risk people. You all drove on a freeway to get here today. I know you are risk takers. So what are the 4 ways to manage risk? Avoidance, thank you. No one ever says that one. Okay. What else? Mitigate. That's the one security folks always go to. We always jump to, how can we put a control in place? How can we control and lock? and squeeze and tighten and make it impossible so that maybe that can get through. So avoidance, mitigation, there's two other ways.
Accept and transfer.
Okay, so you need to understand it to know what the risk actually is, to evaluate. So transfer, I think I heard someone say that.
Yes.
How many of you transfer, and how many of you substitute processing your payment, your PCI, through a third party? You're transferring risk, right? So you've got avoidance, acceptance, transfer, and mitigation. Those are the 4 ways. That's what I love about this slide. Is this the third party processing, right? Or is this, we think we can handle this, we think we can take this on, our controls are good enough, mitigation's the helmet, go for it. Go for the cheese, right? I'm convinced the only way that we can move forward with value-based healthcare and security is with an accurate data inventory. This does not ring more true now than ever, and it's because of every possible input and output of data. It's coming from everywhere. Wearables, laptops, phones, cars, it is coming from everywhere, and it's not going away. To not know where your data is and how it's classified, man, we've got a bumpy road. So whether you're a small shop or a big shop, this is the first and foremost thing to really support a value-based healthcare and a secure value-based healthcare program. Getting an accurate risk register, knowing what your risks really are. So Scott, you mentioned actually understanding your risk. If you are unfortunate or fortunate to have the OIG come in and HHS come in and say, let's talk about why you've had a breach, these are the 2 things they're going to ask you for. Do you have a data inventory? Do you know where your data is? Not where your server physically is, but where your critical data is. And do you have a risk register? Do you know and acknowledge where your risks are? Then classifying it. So technologists love to classify data incorrectly, right? And security folks love to classify data incorrectly. What do you think we typically jump to on all types of data? Critical. Everything's critical, right? Every bit of data is critical. That can be further from the truth. How do you protect and allocate resources if everything's deemed critical? You can't. There's no way. Even the best, most powerful SOC with the best AI in place, if everything's deemed critical, how do you monitor that? You can't. So big emphasis on data classification. When we roll out security programs and controls, we're very invested with the business. We do it in a phased approach. I think one of the most insightful opportunities I had early in my career was handing a technical owner 514 controls and saying, when can you get these implemented? Because if you follow some of the guidelines, that's what you do. But instead you break it up into smaller pieces, and it's much more consumable. So what we say here is every system, regardless of their classification, meets a certain level of security, this tall to ride the ride. And then as that criticality of data goes up, so do the controls and the complexity. I know we're running short on time. I do want to make sure to mention 2 things here. So we've partnered with 6 other large healthcare institutions across the nation and saying, our executives may see us as competitors, but in security, we're peers. So we've actually shared our analytics, our data with 6 other partners and saying, here are the events we're seeing. Are you seeing this as well? And that's worked out very well for us. It's still new. It's kind of awkward at first, but I will encourage you that if you haven't done this yet, talk to your direct competitors are here in this room. Try and see if you can have that conversation where you can say, we're not going to divulge like the gold, right? But if we have a threat come in, we want to be able to share that with the community. We have a strong SSDLC process, so system development lifecycle, where we bake in security from the get-go. Are we perfect at it? Absolutely not. Is there room for growth? Absolutely. But what we're trying to do is take it and get early involvement, especially in procurement. You're going to have folks that will absolutely go subscribe to services. I just got hit up yesterday. Hey, I'm going to purchase this cloud service. Just want to make sure you're okay with that, Matt. I was like, whoa, 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 let's talk through this. And then we're finding ways to streamline so that we don't hold them back. But getting that early involvement before that credit card hits swipe or that contract is signed is key. We've talked about detections and response. Probably the one thing I want to hit on here is just playbooks. For those of you that operate a SOC or have a SOC, are playbooks a part of that? The playbook basically is a step-by-step guide on what to do when they see X event. A phishing email comes in, it's repeatable, right? So you can have folks who are inexperienced know exactly what to do. We would encourage that. It's something we've learned. We didn't develop it, but we would encourage that. 60% of our rules are now based off of AI. And that's all happened within the last couple of years. So again, room for improvement there, but it's pretty cool to see the behavior analytics piece. Medical devices, I think, scare us all, right? The biggest encouragement we'd have is to get testing labs. I don't think we're getting the manufacturers to build in the security quick enough. We're partnering with as many as we can. We're starting to see some traction there, but candidly, it's going to take labs and partnering with startups and breaking these devices. I'm actually hoping that we start seeing bounties and we start seeing other programs where white hats are encouraged to break medical devices, because then you're going to start to see traction. Otherwise, all these IoT devices, wearables that store, transmit, and process our information are just going to continue to be so insecure. Frictionless security is a big method that we're focusing on right now, a big strategy. How can we get away from passwords and focus more on real-time authentication, authorization? So some heavy leaders in this space are already taking very quick steps. We're being a little bit more conservative on this, but I will say that this, along with AI, is the future, right? The idea of 12-character passwords, 15-character passwords, 20-character passwords, and 3 other types of authentication, I think, is not going to last very long, especially in a value-based model where that data is needed real time. So I would encourage you to look at that. We round, every one of our directors round with clinicians on a regular basis. We sit in the rooms with the patients, with the doctors, and we see what's causing them trouble. It took that to be able to see a doctor trying to do this while performing a surgery to say, we should probably not require them to type in a password, but leverage their badge and just authenticate with their badge. So we moved to that model. That came from rounding. In security, we got to get away from these graphics. Delete every one of these graphics from your presentation that you give to anyone in the business. Just remove every one of these graphics from your slides now and put it more in these terms, right? We can provide patching in 15 days on critical patches, but it's going to cost $15 million a year. Or if we do a 90-day period, it will cost $1 million a year. You decide. We're not making that decision. I'm seeing the CISOs nod. We don't make those decisions. But when we present them with, if we don't do this, man, we're owned. We will be in the news. You will have to testify before Congress, right? I mean, that's what these graphics do. These ones start the business conversations. And then lastly, just an example of dashboards. We're big on dashboards and being able to drill down into them. This is a technical dashboard. I wouldn't show this to our non-technical clinicians because it doesn't add a ton of value. But to our folks who are responsible for implementing the controls and safeguards, this adds tremendous value. And it's not real-time data. Unfortunately, I wish we were there. We're not. We will get there. But to be able to know at a high level, just one page above the fold, if we take the newspaper methodology, we can know are we winning or not, right? And don't use 5 billion events from your SIM. No one cares, right? If one got in, one event turned into an incident, I care, but no one cares. So anyway, metrics like that. I want to put you back into your bed at night. That's the end. That's where I want to leave you with. Value-based healthcare will improve quality. It will reduce costs. It will improve efficiencies. But it doesn't come without us thinking, how do we do that in a secure way? Otherwise, we're going to repeat the same thing we do every time efficiency opportunities are there. We're going to move quick, then secure. But if we don't bake this in now, early in that life cycle, we're going to be in a worse situation. So with that, thank you for your time and your comments and for the dialogue, and look forward to more of it. Thank you.